la última conferencia. Damos la
Now,
bienvenida.
the last lecture, we would like to welcome Dr. Philipe Liverneaux from Strasbourg. He's going to speak about something that is not the future anymore, but is rather the present of brachial plexus surgery, which is the use of robotic surgery of the brachial plexus.
Et encore, nous vous remercions de votre présence.
Thank you very much for your kind invitation. Should I share my screen? So I'm Philippe Liverneaux. I am a hand and microsurgeon from Strasbourg University, France. And the goal of this topic is to share with you maybe the future of brachial plexus repair. I mean, could we use a robot to perform a brachial plexus fixation or dissection in case of outlet syndrome? So this picture is to make you see the difference between conventional surgery, when there are a lot of hands around the surgical fields, and the hands are very large. It's the reason why we need to make large incisions to get to the spot where we want to operate. And with robots, on the other picture, you can see that the instruments are very small, very long, and you can go to the target sometimes endoscopically. So you only need to make very small incisions. So I would like to show you today only two surgical techniques that maybe you could use in the future. And I know that surgeons in Germany and in Japan already use this technique. The first one is intercostal nerve harvesting. So this is the technique. So this is a robotic intercostal nerve harvesting from inside the thorax, not outside, like we do usually. So this is an experimental trial. The surgeon is sitting on the surgeon console, and here it's an experiment on a pig with position in the lateral position, and the robot is docked to the animal. And here we are inside the thorax, and thanks to gas insufflation, we can get a very nice view of the operating field. So this was one of our first trial, and we were very precautious at that time. And but actually, it's really very easy to do this procedure. The first thing is to open the parietal pleura. So the first thing is to make sure that you will notice where is the nerve. And when you know where is the nerve, it's very easy to make a dissection all along the rib cage, from the posterior part to the anterior part of the rib cage. And when you notice where is the nerve, it's very easy to make the dissection, as you can see here. So here is one of the first nerves. Sometimes you can harvest 2 or 3 nerves. When you feel that the length is okay, you just have to cut the nerve at the anterior border of the rib cage. Sometimes you can use coagulation, but in most cases it's not necessary. And here we harvest 3 intercostal nerves on that pig. Then we perform some operation on patient, and it's very important to choose the correct portals in order to see all the rib cage in one shot. So thanks to the help of my good friend, a thoracic surgeon, Dr. Santelmo, he teach me how to position the trocar in the rib cage, as you can see here. So we have 1 trocar for the camera and 2 trocar for the instruments, and you have a 3 division inside the rib cage. And there is absolutely no trimmer, and it's very easy to do it after, of course, you master the technique. So here with a conventional endoscopic camera, you make sure that you are in a good position, and then you can dock the robot like you can see here. This is a Da Vinci robot, and I hope that in the future we will have dedicated robots for microsurgery, which could be, of course, easier for us to use. So here starts the operation, same like on the pig, because it's a very close anatomy. And the first step is to to open the parietal pleura. The surgeon, like you can see, is on the surgical console. He doesn't need to scrub at that step of the operation. And you can see that there is no tremor, and the gestures are very smooth. So this is the first step. Gently, you notice where is the nerve, and then you just have to follow the shape of the rib cage, and to open the parietal pleura with these instruments, and then gently you make a dissection of the intercostal nerves, and when you feel you are okay, you just cut at the anterior border of the rib cage the two intercostal nerves. If you need 3, you take 3, and then under the control of the main surgeon, you ask to your assistant to please push on the rib cage in order to notice where you will introduce a trocar to get the 2 nerves outside of the thorax. So here you can see that, oh yes, look, it sounds good. So introduce the trocar. Of course, you have to make sure that there is no damage of the nerve. Then you ask your assistant to take gently with a forceps to take the 2 nerves outside of the thorax. And here, a first example, you can get enough length to perform the neurotization to the biceps nerve or whatever you need. Another example here, you can see that, and here we have very small incisions. There is a drain here. Sorry? Somebody speaking about. Okay, anyway, then we've done a couple of cases, and we on the process to publish our cases very soon.
¿A dónde se lo mandas? ¿A su casa? ¿Al Galenia?
Sorry, somebody else is speaking in Spanish, and I don't understand. But anyway, I will go further. So the second operation I would like to share with you is a C7 crossover transfer. This is a trial on a cadaver, and so you can see that 6 trocar on the left with a very small incisions compared to the large incision, which is the conventional that you use in conventional surgery. So first of all, here is a trial. So you can see that the surgeon is on the surgeon console, a couple of meters away from the patient. And here we start to perform the dissection of the right side of the brachial plexus, which is supposed to be the healthy side. So here is the clavicle, and then we go on to dissect the soft tissue up in the skin, down in the brachial plexus, and after a couple of minutes, we can see where the phrenic nerve here, and then we go on the dissection, and we get all the entire brachial plexus. And the next step is to notice where is the C7 root on the healthy side here, and we will try to reach that root as far as possible, as distal as possible to the clavicle. Then we cut it, and then we will transfer it between the spinal cord on the left and the esophagus on the right. We push on it, like here, and this is totally endoscopic. There are very small incisions. Then we are going to the left side, which is supposed to be the injured side, and we perform here the dissection of the left brachial plexus, and you can see here the phrenic nerve and the C5, C6, C7. And then here we will cut the C7 root as proximal as possible. So here is the C7, then we cut it, and then automatically we get that 7 root, the left one. You can see on the very left of the picture the right C7. We pull on it, and then we will push the left C7 and put the both together. Then through another trocar, we will introduce a suture. So, and then we get the suture through the trocar, and then we perform the suture as usual. Here, because it's an experiment, we use a 7/0 suture. Of course, usually we use smaller ones, and we go through the root, proximally, and then to the left C7, and we push on the needle, and then we tight the first node. And you can see that here that there is absolutely no tension between the two C7. There is no need for a graft. And okay, don't think it's so easy, because it took more than 1 hour to take this experiment, but it's possible to do it. And so here we perform the first suture, then we will do the second one here. And this is the entire suture. And you can see that with 6 very small incisions, we were able to perform this operation strictly endoscopically. And you can see on the left the drawing of the conventional dissection. So with these 2 videos, of course, we can do many different things endoscopically in brachial plexus surgery. And but if you are interested to learn how to do this technique, okay, a couple of surgeons made a scientific society called the RAMSES, Robotic Assisted Microsurgery and Endoscopic Surgery Society. And with my friend Jesse Selber from Houston, Texas, he's a mostly plastic surgeon and mostly orthopedic surgeon. I am more involved in nerve surgery, and he's more involved in vascular surgery. And altogether, we organize sometimes some courses. And if you are, we will be very pleased to invite you to attend to these courses. So it's only a technique. It's not a revolution. It's only an evolution. And this could make endoscopic surgery endoscopic or less invasive like usual. Thank you for your attention.
Thank you, Dr. Liverneaux. This is just an overview for the future, and we hope to be able to have this in the future. Now, I would like to invite all the panel members to have their cameras and microphones on for a discussion period on this module. So we have some questions. Dr. Gilbert, do you think that we have reached this final limit in the reconstruction of brachial plexus regarding anatomic restitution? What remains is too limited after this reconstruction inside and outside the plexus. Do you think that we have reached the limit?
Hay un otro que tiene más, que es mejor que nosotros.
We think that this is a limit, but always we have something else going further on. I think that the main problem is that there are some difficulties, biological difficulties, which is regeneration, nerve regeneration with time, and the possibilities of this remote regeneration or distance regeneration is something that we do not yet control. We talk only about techniques, and techniques are not the solution. The solution is going to be a biological solution, and it could be that we may have them in the future. We will still have additional breakthroughs, and maybe not in the hands of surgeons, of course. There is a question from the panel. There are problems with the movements, independent movements. If you use the C7 contralateral, are there problems for moving the patient? No, usually no, because this is a repair of the trunk. We don't have enough outcomes, enough results, successful results to see if really we have this independence. But my response will be no. Dr. Shin, there is a question. Fixation of the second gracilis, is it not restricting movements of abduction of the shoulder? When you fix the second gracilis to the rib, are there any limitations in movement?
There's not very many limitations. The gracilis has a very large excursion. And so, in fact, it works better with the arm abducted a little bit, but there is not. Going back to the question of independence with contralateral C7, our group has largely abandoned the use of contralateral C7 in adults. We've had extremely poor results and have not been able to replicate the function and outcomes of Professor Gu. And independence has been a huge problem with our patients, where some patients have actually asked us to take down their contralateral C7, especially if it was used for elbow flexion, because they can't do anything with their injured arm without using their normal arm.
Esta es una pregunta de pronto para todo el
This is a
panel.
question for the panel. What do you think about neurotization with these end-to-side sutures? Dr. Gilbert? I can talk about this because I have published 15 years ago a series of the brachial plexus with the end-to-side sutures. The problem is that we have some very good results, a few, some zero results, and in the middle, a little bit of good results. And the end-to-side suture could be useful in some cases where we don't have any other solution. But to do this on a routinary basis is not valid, because we have many cases where we don't have any results. This was published in the neurosurgery journal. Professor Merli?
Yes, the problem with end-to-side suture, if you do an experimental work on the rat, sometimes it's work because it's the rat. If you do the same thing on the adult, I have exactly the same answer than an bear, because you have no possibility to know what it's work really. Probably some fibers go through the suture, but more frequently is a sensitive result than a motor result. I am not sure that is a method for the future at this time.
I have to agree with both Professor Gilbert and Professor Merrill. In our hands, end to side is a big mystery, because some surgeons will say you have to make a epineurotomy and damage the neurons or the nerve fibers for it to work. Then it's really not end to side. So there are so many variations that we have to be able to talk the same talk. Putting the nerve end to side in our hands does not give the results that other people have in the literature. So I'm in agreement.
En cuanto al síndrome de salida torácica.
Regarding this syndrome of the thoracic outlet, Professor Merli.
Yes, I appreciate the talk done by my colleague from Mexico. I agree. We need to talk now about a neurogenic thoracic outlet syndrome, because it's the majority of the pathology now. If you observe the evolution of the surgical practice done by the vascular surgeon, they stop to remove the first rib, because many vascular surgeons operate too many patients to remove the first rib, because they have seen on the arteriography an entrapment of the subclavian artery. Or if you do an arteriography for yourself, you have in 60% of cases the same image of compression of subclavian artery without the neurological symptom. And be careful, it's necessary to do a very nice, precise clinical examination to demonstrate that is only a pure neurogenic thoracic outlet syndrome in 96% of my experience. I would like to do a comment on a question for Dr. Raphael Reynolds. Why you don't explore the subclavian, the costoclavicular space? Because in my experience, in 50% of my cases, is necessary to remove the Caldani ligament. Caldani ligament is very strong, and the risk is to develop some entrapment of the trunk of the brachial plexus, and sometimes from the subclavian vein. I would like to know what is the experience about this surgical approach for the subclavian and the costoclavicular space.
Gracias, Dr. Merle. Rutinariamente
Thank you, Dr. Merle. We explore on a routinary basis every level below the clavicle. If we don't have evidence that we suspect that there is something else, then we stop here. But frequently, we end exploring as well the level below the pectoralis minor. The Caldani ligament, I agree, is a cause of compression that is important and has to be taken into account, or is a cause that in some cases symptoms do not disappear when we have done surgery in a patient if we have not considered this Caldani ligament. So we have to take this into account. As you see, we are doing exploration and treatment, careful treatment of each of the levels, and maybe this is why we have so good results. We cannot publish and continue always with the same idea that this is just a dark type of pathology that is not very frequent. It is more frequent, and they can believe this pathology, and is present and is seen in those cases where we have multiple entrapments and multiple painful symptoms on the limb. We always have to think about this. It's not just a pathology that is seen in a few cases. I do join and I accept the comments with this end to side suture. We use it only to sensitize. It's good to sensitize. Or when we do the babysitter in this part, we have an injury of the ulna to maintain the motor plates while we have the repair. These are the only two cases we use this with confidence. It's not a good technique because it doesn't allow us to have a predictable result, this end-to-side suture. Any experience, Dr. Liverneaux, regarding robotic surgery and thoracic outlet syndrome?
A good question, because yes, actually I don't have so much experience in outlet syndrome, because when it's a neurologic one, I operate only when there is a thinner amyotrophy. I mean, in my experience, most of outlet syndromes, they are, if they are not vascular, they are mainly psychological. So, I operate maybe just a couple of them, and I have to confess that I never used yet a robot, but probably it could be a good idea, because even if the incision is very small, when you perform this outlet syndrome release with a conventional procedure, the interest of robot is that the incisions are a little bit away from the site of the neurolysis. So that means in terms of scar tissue around the spot of the neurolysis, probably if the skin incisions are away, maybe we'll get less scar tissue around the nerves you just released. But it's only a theoretical point of view. I don't have enough experience to tell you that yes, robotics could help you in this kind of indication. So I don't want to lie and say that it's a good idea, because I don't have enough results actually enough experience to tell you that in this indication it's a good technique.
Gracias, doctores Gilbert, Sheen, Merle.
Thank you, Dr. Gilbert, Sheen, Merle. Liverneaux and Reynoso, thank you very much for your very kind participation in this discussion. We hope to have you back in Colombia and to have you here in Colombia physically.